Hello, everybody. I'd like to welcome you to our today's ERKNet webinar on IgA nephropathy. My name is Jens König, and I have the great pleasure to introduce Professor Marina Vivarelli from Rome. For most of you, Marina will be a familiar face since she has presented several ERKNet webinars in the past and is an outstanding expert not only on glomerular and complement-related diseases, but basically has an answer to any kidney-related question you can think of. That's at least my personal experience. Professor Vivarelli was trained a pediatric nephrologist at the University of Padua in Italy and completed a research fellowship at Harvard University Children's Hospital in Boston. Since 2023, she's the head of the Laboratory of Nephrology and the Clinical Trial Center at the Bambino Gesù Children's Hospital in Rome. Marina co-chairs the ERKNet working group on TMA and has been involved in the development of several IPNA and KDIGO guidelines, such as the ones on nephrotic syndrome, glomerular diseases, and complement-mediated renal disease. And today, Professor Vivarelli will give us a lecture on the IPNA IgA Nephropathy Guideline that was just released recently. Marina, it's a great pleasure to have you here again, and we are excited to follow your presentation.
Thank you so much, Jens. Thank you to everyone who's participating in this webinar. I hope you can hear me loud and clear. And what I'm going to do is that I'm going to give you an overview of one of the two parts of this clinical practice recommendation that we put together as a group of experts under the organization and support of the IPNA Best Practice and Standards Committee. And it's the part that regards the diagnosis and management of children with IgA nephropathy. The guideline, as you know, is already published in pediatric nephrology, and it covers also IgA vasculitis with nephritis, but today we're going to focus on IgA nephropathy. So the slides are the slides that were presented and prepared for teaching purposes by the Best Practices and Standards Committee, specifically by Arifa Aladdin, who I thank very much. And then I added a few slides of my own just for some commentary. And I'll obviously be glad to take questions at the end. So the outline is that we're going to talk about the rationale, the method of development, the definitions, and then for IgAN, the diagnosis, treatment, and follow-up, recommendations and suggestions that the group of experts came up with. So the rationale for this guideline is pretty clear. IgAN, IgA nephropathy, is the most common primary glomerulonephritis in the world. Its annual incidence in children is 0.2 over 100,000 children, with a median age of presentation of 10.9 years. The disease characteristics and the frequency of the disease vary very much by geography. You know that it's much more frequent in Asian countries, where, for example, there are urinary screening programs that allow the detection earlier than in other parts of the world. And it is also a disease in which practice variation, so the management, if you look at different geographical areas of the globe, is very different. It is also an important disease because even though it doesn't have often a very dramatic presentation, it is one of the leading causes of chronic kidney disease and of kidney failure, with up to 50% of children progressing to kidney failure after 30 years of follow-up. So it's a slowly progressive, quite insidious and subtle disease that in the long run can give a lot of problems in terms of kidney function to a vast percentage of the children affected by it. The aim of these guideline recommendations was to optimize care, reduce harm, and decrease practice variation. What we had to start out with was the evidence review tables that were prepared by an evidence review team. That was the team that was also preparing the Cochrane review tables for the Cochrane review for IgA vasculitis and nephritis in children. This team was led by Susan Samuel together with two of her collaborators, and their impulse in giving a validity, scientific validity to this guideline was crucial. The methodology was, as it always is, in following the guidelines that are the same for all IPNA clinical practice recommendation papers. We start with a right statement. We assemble the core group with 27 members. Within this group, we have also patient representatives. We had mostly pediatric nephrologists, but we also had a couple of adult nephrologists. We had pathologists, giving the importance of kidney biopsy in this condition. We had 2 pediatric rheumatologists for support for the IgA vasculitis. And the patient panel looked at the guideline once it was complete and gave some suggestions on how to modulate it to make it clear and to make sure that we respectfully took into consideration the patient's point of view as well. So the first work that the core group did was to draft recommendations for each PICO question based on evidence that, as I explained to you earlier, was provided from the systematic literature review team. And to then, once those recommendations had been drafted, and this happened over various meetings via Zoom and 1 meeting in person, to then grade the recommendations and suggestions that had been created. After this had been done, there was an expert voting panel. And a Delphi method was used so that for each specific recommendation or suggestion, a level of agreement of 70% or above was set as necessary for that statement to be left as it was. If it did not reach this threshold, it was reformulated, modified, and then went through a subsequent Delphi process. And then after this was done by our core group of experts, it was also reviewed by external experts, 24, chosen by all the different societies of pediatric nephrology all over the globe. We then reviewed their recommendations and revisions, changed once again the manuscript, submitted it for publication of Pediatric Nephrology. It underwent 3 rounds of revision during the publication process, during which it was again slightly modulated and changed, always with full agreement from all the involved co-authors, and it was finally accepted for publication. So the methodology, the American Academy of Pediatrics grading system, I'm sure you know it very well. It gives levels based on the quality of the evidence available for each PICO question. So level A is when you have very high quality of evidence. Level B, when you have trials or diagnostic studies that have, however, minor limitations. Level C, when the studies are observational, single or few, or otherwise there are multiple studies but they have inconsistent findings or major limitations. Level D is when you just have expert opinion or case reports. And then there's a special level, which is unfortunately very frequent in the pediatric world, which is level X. Level X is when you have a situation where you don't consider it necessary to perform validating studies because the benefit is clearly predominant over the harm of giving that statement, and therefore that statement can be made. Essentially, it's based on common sense and routine clinical practice. But this can be a little tricky in some situations. So let's start with the definitions. Regarding IgA nephropathy, it is very clear and important to say that the definition is a definition that is bioptic. So a kidney biopsy defines IgA nephropathy when you find dominant or co-dominant IgA glomerular deposits, which can be mesangial or mesangial and in the capillary wall. Plus, you have to exclude a series of differential diagnoses on clinical or pathological grounds, and we'll talk about this a little bit more in detail. We also introduced clinical definitions of different stages of IgA nephropathy, in which we try to be in line with the current literature, in line with the definitions that have been given for nephrotic syndrome in children, and also to be very prudential, recognizing that proteinuria in children is always abnormal, and it has to be cut down to below what is considered the threshold of normality in order to be sure and confident that we are not accruing damage by having even a very low level of proteinuria spread out over a long period of time. So we defined remission of IgA nephropathy as the resolution of proteinuria for at least 1 month, which means that you have normal or negative proteinuria defined as a UPCR below 0.2 milligrams over milligram, or below 20 milligrams over millimole on the first void, or if you have the 24-hour, below 0.2 grams per day on 2 urine samples at least 1 month apart. Plus, to define remission, you also have to have normal or stable eGFR. And if you want to talk about complete remission, given the importance of hematuria in IgA nephropathy, in addition to the first 2 points of the remission definition, you also have to have resolution of hematuria, defined as having below 5 red blood cells per high power field, or negative dipstick for hematuria. Relapse in a child who has previously achieved remission is instead defined as a reappearance of proteinuria on 2 urine samples 1 or 2 weeks apart. In addition to this, you expect to have hematuria, and you may or may not have reduced eGFR with an eGFR below 90 or more than 25% reduction from baseline. In terms of patients who have lost their kidney function and been transplanted for IgA nephropathy, we defined recurrence as a transplant kidney biopsy showing glomerular IgA deposits in a patient who previously, on his native kidneys, had a history of IgAN or IgA vasculitis with nephritis. So on a transplant kidney biopsy, a recurrence is diagnosed purely on histological grounds. So in terms of assessment and diagnosis of a child with a clinical picture that can be compatible with IgA nephropathy, the group recommended an initial assessment in which it was important to obtain a careful patient history for kidney and also for systemic manifestations, a detailed physical examination, and also performing both blood and urinary tests. And I'll go through rapidly the table, which is present in the publication table too, where we look at all this in detail. The goal of the initial assessment is to exclude other elements. For example, IgA vasculitis, secondary causes of IgAN, which in children are not that frequent, such as liver disease, viral illnesses, and IBDs, but they can be present and they can give pictures that are very, very similar to classic primary idiopathic IgA nephropathy. And also to exclude infection-related and post-infectious glomerulonephritis, which we know in children can present with a clinical picture that is very, very similar to that of IgA nephropathy. In terms of urine tests, it's important to quantify proteinuria to document hematuria, and also in older children to exclude orthostatic proteinuria. And also it's important to all calculate the estimated GFR in the same way using the modified Schwartz formula. So this is the table. There are 3 slides looking at the table of initial clinical assessments. It's pretty much common sense of what you would expect to do, but it's not always nice to have it all written down. So you take a careful patient history, and in this you look for secondary causes. You look for signs or symptoms of systemic diseases, which can be different from IgA nephropathy. So fever, swelling, pain, abdominal discomfort, loss of weight, loss of school attendance. You also, in certain endemic areas, check for tuberculosis before starting immunosuppressant drugs. In terms of physical examination, you check for signs of edema. If the patient is already on steroids, you check for steroid toxicity, but this is not valid at initial assessment. You always have to check for extrarenal features, which can point you towards other forms of vasculitis, which can present in a similar way to IgA nephropathy. You check the pubertal status and the vital parameters, in particular the blood pressure. You always have to take anthropometry with the growth chart, so height or length, weight, and BMI. In terms of labs, the most important is obviously the urinary ones, but also the CBC, the renal function, the electrolytes, the serum albumin, and total protein, which can give you an idea of a nephrotic syndrome present or not. CRP to understand if there's a potential infection. This can be done or not done depending on whether there are signs of infection. You can calculate the GFR. It can be useful to check the vitamin D and PTH status of the patient. The lipid profile can be useful if the patient has a nephrotic range proteinuria. It can be useful to check baseline coagulation, especially if you're considering performing a kidney biopsy. Only if the patients have nephrotic range proteinuria, you check thyroid function. If you suspect that there may be a systemic involvement, you check circulating C3, especially if there's a post-infectious form, and IgA levels. These two exams, if it's not too difficult, are actually quite important to obtain. In case of recurrent infections, IgG levels can be useful. And if you suspect a vasculitis, anti-nuclear antibodies, anti-dsDNA, ENA, and ANCA are important. And then if you're planning to start immunosuppression, in particular steroids, checking for a variety of in severe infectious diseases such as hepatitis B, hepatitis C, syphilis, HIV, and tuberculosis, as appropriate depending on the country, and the patient history can be important. This is certainly the most important exam for the diagnosis and initial assessment of IgA nephropathy. So we know that the distribution of this disease is very different depending on the countries. This is the beautiful picture from a recent review on IgA nephropathy. And we know that urinary routine screening in some Asian countries has led to early recognition of the IgA nephropathy and prompt treatment. So the other important initial assessments are at presentation, especially if you're planning a kidney biopsy, to perform a renal ultrasound. Only for patients with a nephrotic range proteinuria, an ultrasound of the abdomen and possibly of the pleural space. Cardiac ultrasound if they're hypertensive. And then there's the renal biopsy, and I'll give clearer indications for that. It is absolutely necessary for diagnosis of IgAN. Subsequently, if indicated, and in particular, if there's an important sign of a severe relapse with an unexplained drop in eGFR. It is also super important to provide dietary guidance and assessment, because this is a disease in which lifestyle correction can be very important in the optimal management. These are probably the three most important assessments of this table. So in terms of diagnosis, we know that a kidney biopsy is required. So we recommend considering the possibility of primary IgAN if you have hematuria. We know that children with IgAN very often have gross hematuria, but they can also have microscopic hematuria with proteinuria, which can be also mild. If it persists over 2 to 3 weeks, and at least 2 clear urine measurements 1 to 2 weeks apart. So if there's the hematuria, but then after the hematuria, you continue to have proteinuria. And obviously what you need to exclude are lower urinary tract etiologies or features of systemic disease, and the post-infectious forms by checking that the serum C3 level is normal. We also suggest considering the possibility of primary IgAN and therefore considering a biopsy if there is gross hematuria, which is very persistent or very recurrent, every time there's an upper respiratory tract infection. So in this case, if it's very persistent or very recurrent, even in the absence of proteinuria, it can be considered useful to perform a biopsy and have a diagnosis of IgAN. We recommend performing a kidney biopsy promptly if, in addition to the hematuria, which is persistent and recurrent, there is also nephrotic range proteinuria and or reduced eGFR. We also recommend a kidney biopsy if, in addition to the hematuria that is persistent or recurrent, we have a proteinuria that is significant with a UPCR above 0.5 and at least 2 measurements. We also suggest a kidney biopsy if the hematuria is persistent or recurrent, even with a very low degree of proteinuria between 0.2 and 0.5, which is still pathological, still abnormal, in at least 3 measurements on clear urine 1 to 2 weeks apart. This is schematized here, and I just wanted to show you one thing. So we put a very low threshold of PCR, of urinary PCR, to perform the biopsy because we really want to avoid underdiagnosing this condition, and because we know how subtle sometimes the presentation can be clinically, but despite this, we can then find important lesions on the kidney biopsy. The RAS blockade, doing flowcharts can always be a little bit confounding. So if you look at it this way, it can look like we're suggesting the RAS blockade before you even perform the kidney biopsy. This is not true. It's simply that we put a low threshold for starting RAS blockade because we know how crucial it is in children. And so it's the same level as the lower threshold for performing, if it's persistent, kidney biopsy. So normally we would imagine that the RAS blockade and the kidney biopsy are more or less started at the same time in these kids. underlining the importance of precocious beginning of RAS blockade in IgAN optimal management. So it is also important to consider, particularly in children, which can be the major differential diagnoses. And I'd like to bring your attention to the fact that these two genetic diseases, thin basement membrane disease and Alport syndrome, which are part of the same spectrum probably, are the most important and frequent differential diagnosis in children. And this is important to keep in mind, so the importance also of making an accurate family history, of looking for sensory neural hearing loss and or ocular abnormalities, because here the diagnosis can also be done through genetic testing or through skin biopsy. So it's important to keep in mind the possibility of one of these conditions. Post-infectious GN is also very frequently in differential diagnosis in children. Lupus nephritis, and here you look for the systemic symptoms and also obviously the low concomitant C3 and C4 with the positive anti-nuclear and anti-double-strand DNA antibodies. The IgA vasculitis with nephritis, you're going to have the purpura, and the ANCA-associated vasculitis, you're going to have often the rapidly progressive forms and then the positivity of the antibodies when you look for them. So in the monitoring and follow-up of this disease, how should we behave? So first of all, the group really felt that it was important to remember that this is a disease that persists for decades. So the group felt strongly that they would recommend long-term follow-up in children with IgAN, including in children who have achieved complete remission, because this disease can relapse after many years. It was also recommended to adjust follow-up intervals based on the severity of the symptoms, of the histopathological features of the treatment regimen, and of the response. So that's common sense. And it was also suggested to reevaluate etiology to exclude secondary forms if there wasn't a satisfactory response to initial management. In general, it was recommended to perform lifelong yearly monitoring of a child who's had who has received a diagnosis of IgAN in terms of blood pressure and urinalysis. And this was really felt strongly to be something that would optimize the long-term evolution of these children. It was also recommended upon diagnosis to offer the child psychological and social support on a case-by-case basis. In terms of management, so first of all, there was the optimization of supportive care. Here, there's a lot of excellent evidence coming from studies performed mostly, but not only in adults. So it was pretty easy to give these indications. So in all patients, even with slightly abnormal, but above or equal to 0.2 milligrams over milligram, or above or equal 20 milligrams over millimole of UPCR, it was recommended to optimize supportive care. And by this we mean dietary counseling to moderate salt intake below 3 or 5 grams per day, treatment with RAS blockade, either ACE inhibition or angiotensin receptor blocker at the maximally tolerated doses, aiming for a UPCR below 0.2 milligrams over milligram or below 20 milligrams over millimole. It was also recommended to maintain blood pressure within normal values in children with IgAN and CKD stage 1. If the CKD stage was higher, it becomes important to be a little bit more aggressive in our blood pressure control, so to target 50th percentile or 75th percentile in those that had both the CKD stage 2 or higher and proteinuria above 0.5. In patients who have even a minimal amount of proteinuria, in addition to this, regular aerobic exercise, targeting ideal body weight, and no smoking and vaping for adolescents, and also counseling children and parents on increased risk of kidney disease progression in children who are overweight and obese, including nutritional counseling, was considered very important. It was not recommended to introduce specific treatments in children with no risk of progression. And it was recommended to perform regular reevaluations since, as I mentioned earlier, the risk may change during follow-up. So in terms of when to perform different types of supportive care, I think it's been very clear. What we had a lot of difficulty on, and I'm gonna try to give you some insight into this, was on the indications for the use of glucocorticoids in children with IgA nephropathy. Here we know that the practice all over the world varies hugely, and that there's unfortunately very low evidence to guide treatment of children with IgAN in terms of the use of glucocorticoids. We also know that there have been some adult studies that have pointed to the fact that glucocorticoids can be not particularly beneficial and also in some cases detrimental. However, overall, the vast majority of experts feel that there is a difference in the management of IgAN between children and adults, and that in children you should be much more proactive about starting glucocorticoids because the lesions tend to be much more inflammatory, therefore much more susceptible to benefit from glucocorticoids, and because the long-term benefit is much more crucial to obtain in a form of disease that is going to last for so many decades because the child is small at diagnosis. So this underwent a variety and a long process to find consent with Delphi process that went through 3 times, and then extensive revision with comments by the external reviewers and also by the reviewers of the paper to obtain the final text that you see in the published guidelines. And you will see that one thing that I wanted to make very clear was that what you see in this scheme is a little bit general, and you really need to read carefully the actual guideline to understand what was the guidance provided at the end of the day. So in terms of thyroid indications, if you look at the text, it is said that in general, the routine use of glucocorticoids, so the use of glucocorticoids indiscriminately for all children was not recommended with IgAN. It was, however, suggested, and we had to use the term suggest because of the low quality of evidence, to consider treatment with steroids in selected settings based on the risk assessment. So to use glucocorticoids in children with a clinical risk of progression. The clinical risk of progression was defined in 3 ways. A, children with a UPCR between 0.5 and 1 milligrams over milligram, therefore corresponding to 50 to 100 milligrams over millimole, despite 3 to 6 months of RAS blockade, or a UPCR above 1 milligram over milligram, so above 100 milligrams over millimole, despite 4 weeks of RAS blockade, or starting from the moment of diagnosis, if the child has active MAS-C scores with 1 or more of the following scores, M1, E1, S1 with podocyte lesions or C1, and or a UPCR which is consistently, so 2 to 3 weeks and at least 2 measurements, 1 to 2 weeks apart, above 1. We know that data from randomized controlled trials in children with IgAN are scant and often inconclusive, and this makes it very difficult to give guidance. So in terms of what you do when you do give the oral glucocorticoids, we gave the doses both for the oral glucocorticoids and for the pulses based on the published evidence. We also put a long paragraph where we talked about the risk-benefit balance of glucocorticoid side effects. We said that in selected cases, the use of glucocorticoids can be considered concomitantly with RAS blockade, particularly either in the presence of nephrotic range proteinuria or in the presence of reduced eGFR and crescentic or actively inflammatory histology. We also considered to avoid glucocorticoids if there's more than 50% of tubular interstitial scarring, and that the target of treatment is to reduce proteinuria to below 0.2. If there's no response within 3 to 6 months, you consider rebiopsy and modifying treatment. This is very important because I want to make it very clear here that these selected cases, you can even have exclusively the active inflammatory histology, regardless of the degree of proteinuria, so that we recognize the fact that in some cases, the kidney biopsy can be more important in terms of prognosis than the proteinuria, or at least that our knowledge of the role of the prognostic power of the kidney biopsy in children with IgAN is still quite uncertain. We also suggested considering the use of additional immunosuppressive drugs in combination with glucocorticoids in some selected settings, which are rapidly progressive IgAN with acutely decreased eGFR, as is also stated in the 2021 KDIGO glomerular nephritis guideline for ANCA-associated vasculitis. So all forms of rapidly progressive glomerular nephritis, whether it be IgAN or something else, needs to be treated in the same way with aggressive anti-proliferative and anti-inflammatory treatment. IgAN with nephrotic syndrome and failure of glucocorticoids. And we recognize the importance, and I'll mention this a little bit more further on, of enrollment in clinical trials for children not benefiting from RAS blockade and steroids. We also gave indications for supportive care and tonsillectomy. So vitamin D should be given following international guidelines for vitamin D supplementation. Immunizations, we should follow the national immunization guidelines according to age, and live vaccines should not be given to children receiving daily glucocorticoids and or immunosuppressive medications. Fish oil and tonsillectomy were reviewed, the evidence for these, and it was considered overall not recommended. We also recognize the existence of forms of atypical IgA nephropathy. And so we went through these forms and detailed them so that it would be very clear that these forms need to be treated in a different way. So we recommend treating children presenting with nephrotic syndrome and minimal change disease on a biopsy that also has associated IgA deposition as if that child had steroid-sensitive nephrotic syndrome. So following the guidelines that are published on this topic, because we know that one of the different histological pictures in children with steroid-sensitive nephrotic syndrome that receive a biopsy can be a minimal change disease with associated IgA deposition, but this is not IgAN. It's a steroid-sensitive nephrotic syndrome child that has a particular histological picture, but clinically behaves exactly like SSNS, and therefore needs to be treated in this way. We also addressed children presenting with rapidly progressive GN, as I have mentioned even before. If you have a rapidly progressive form, so an unexplained more than 50% decline in eGFR in less than 3 months, you have to treat that patient as if he or she had rapidly progressive GN, irrespective of the fact that he or she may have IgAN. That child will also have endocapillary proliferation at least E1 and crescents at least in 25% of glomeruli. And at that point, you will treat that child with IV glucocorticoids plus or minus other immunosuppressive therapies such as cyclophosphamide or mycophenolate mofetil as per guidelines for RPGN. This is all put down in this graph, and I wanted to underline how, in addition to the graph, the fine print has to be read carefully. When you're going through the follow-up of these children who need to be reevaluated every 3 to 6 months, you have to point for complete remission. If you obtain that, you withdraw immunosuppression, you withdraw after a long time RAS blockade. Otherwise, you have to be proactive about repeating a kidney biopsy, enrolling in a clinical trial, and adding immunosuppressive drugs and optimizing supportive care. Supportive care only is for those children in which you feel that there is no margin to further benefit that child, considering the extremely progressive form of disease that the child has, and we have to try avoiding to get at this point at all costs. So I wanted to show you this beautiful picture from this very recent review in National Review Nephrology on IgAN to show you how many treatments there are in clinical development for IgA nephropathy with agents targeting the inflammation of the gut mucosa, where we know that the B cell priming occurs, such as Nefecon, and so targeted release budesonide, B cell directed therapies with agents targeting APRIL plus BAFF, or plasma cells, so CD38. Complement inhibitors with agents targeting factor B, factor D, C3, C5, and the C5a receptor 1. And also antiproteinuric agents such as endothelin receptor antagonists, both sparsentan and atrasentan. So keeping this in mind, I really think that it's important that in the clinical guidelines, we try to push pediatric nephrologists all over the world to consider and be proactive and aggressive in trying, obviously in a controlled fashion, these new agents within by enrolling their patients in clinical trials whenever possible. So let's look at the important data that has come from the RADAR study published in CJASN in 2018. In terms of prognosis, when we look at the time to kidney failure or death, children tend to do much better compared to adults. We think that this is mainly due to the fact that children, largely because they have macrohematuria at onset, are diagnosed sooner. It is also important to see that even in the upper echelon of patients in which you go to a level of proteinuria, which is a ratio of 0.44, so very low, which in the adult world would be considered not particularly significant level of proteinuria, not in the first 2 or 2.5 years significantly, definitely not in the first year, but over time, any degree of proteinuria brings to an accumulation of damage. So this is furthermore a call for action to be proactive in bringing down with appropriate management the proteinuria below 0.2 as stated in the guidelines. So in terms of definitions of remission and relapse, I just put them here again to show you why we were so stringent, and I hope I've convinced you that I think we were right to be so stringent. In terms of relapse, important to diagnose it early. At that point, again, we suggest implementation of optimal conservative treatment and then to treat as per initial treatment. In terms of treatment discontinuation, it was suggested that it was reasonable to consider discontinuation in children who achieved a full remission for at least 12 months, and that it was suggested to continue supportive therapy with RAS blockade, individualized according to the severity and response to treatment, and also I would like to add to the blood pressure of the patient. In terms of post-transplant recurrence, as I mentioned earlier, it was recommended that the diagnosis be performed with a kidney biopsy, not based on proteinuria or hematuria, which especially in the setting of a transplanted child can be particularly difficult to discern. At that point, you obviously optimize supportive care. You give maximal RAS blockade. You do not implement glucocorticoid withdrawal. You enroll in clinical trials if the proteinuria persists, despite adherence to transplant immunosuppressive regimen and despite optimal conservative therapy. And the treatment options are the same as per initial treatment of IgA. We hope to have many new agents in the coming years for these difficult patients. We also gave recommendations for transition. This is particularly important in a disease that goes on for such a long time. So we have to plan for transition and be proactive about making sure that our patient does not feel abandoned in this pivotal moment. So the adult units need to have trained staff to help young people, parents, or caregivers with this phase. A transition plan needs to be developed between multi-professional team and the young person. There needs to be a named transition worker that makes sure that the transition happens smoothly and that is available for at least the first 6 months after the transfer and before to provide a sort of point of contact for the person who is being transferred. Self-management needs to be supported and encouraged in order that the patient is able to make his own decisions and choices to improve his or her health and well-being. Information needs to be given specifically for young adults in adult units. Giving information that is pertinent to 60-year-olds is not helpful in this setting. Counseling about career, financial, and benefits needs to be given. And also it can be very useful to have access to a peer support network. So these were the recommendations that our adult nephrologists made together with our pediatric nephrologists in the core group. Overall, what I wanted to sort of point out is that in terms of research questions, I think one of the most pressing one is we know that there have been beautiful papers showing that, and this has hugely helped the progress of clinical trials for IgA, that the proteinuria really drives the accrual of chronic kidney damage over years. However, what we do not know is, does the proteinuria reflect accurately the underlying kidney damage? So this is a sort of call for action. I think it's really important to try to understand clearly, especially in pediatric forms, how well the proteinuria correlates with the underlying kidney biopsy lesions. And I think, therefore, using criteria based on kidney biopsy lesions moving forward is of crucial importance, in addition to the proteinuria, to guide our management decisions. So this is the manuscript with the DOI, and it's obviously free to download, both on the IPNA website and on PubMed. So I'd like to conclude by acknowledging the huge amount of work that went into this guideline by the IPNA Guideline Committee, the IgAN Foundation, the IPNA Regional Societies, all of the people who participated in the guideline, Dr. Arifa Aladdin for preparing these slides, and Professor Mark Haas and Alexandra Cambier for thoughtful considerations and criticisms that made me modulate this talk and try to give this information in a as complete and clear manner as possible. Thank you very much for your attention, and I'll be glad to take questions.
Thank you very much, Marina, for this nice and comprehensive presentation of this very complex disease entity. I have one question in the question box, and I would like to motivate everybody who wants to raise questions to put them in the question box, and I will read them out. The first question is from Antonio Gargiolo. I hope I pronounced that correctly. Can celiac disease screening be useful?
That's a really good question. We talked about that with our colleagues who are gastroenterologists, and in the end we decided not to put it in, just because both celiac disease and IgAN are very frequent diseases, and because there has been shown to be a correlation and some potential overlap in terms by genome-wide association screening tests in terms of predisposition. But we felt that the indication to perform screening for celiac needed to come from the recognized symptoms and signs that lead to celiac screening. We actually had tried, for example, in Rome in our center, to perform screening for celiac routinely in all patients with IgAN, and we did this for a couple of years, and we didn't have the impression that it was really helping us clinically, and it is of course quite expensive. So overall, it's something that is very thoughtful to consider, but we did not feel that it was that there was at this point in time evidence for it to be recommended routinely.
Okay, thank you very much. As long as there are no other questions, the question box, maybe I might ask a question. I was wondering, in what percentage actually do we expect or observe complete remission in terms of complete resolution of microhematuria? In my personal experience, I would say that's quite rare, isn't it?
Yeah, so that's a really good question. So that's actually something that even in the literature is not covered very much in detail. There's a recent paper that was published in Pediatric Nephrology, actually, that came from a reassessment of the patient cohort here in Rome, in which we tried to give a definition of complete remission, and it's quite similar to the definition that was given in the guidelines, even though this was done by other members of our group. So it was interesting that we came up with a similar definition. And we did see that there was a percentage that even over a long period of time goes into complete remission, intending no proteinuria, no hematuria, completely normal kidney function in the absence of RAS blockade. The thing is that you tend to forget about those patients because you don't see them. And this was also one of the sort of call for action that came up in our screening and follow-up indications that we then gave, to try to really make sure that people would continue to see these patients at least once a year because of the very real risk of a relapse. So, but I would be moderately optimistic that if managed correctly, a substantial percentage of these patients can go into absolutely complete remission and prolonged remission.
Okay, thank you very much. I have further questions, but please challenge me and send me questions in the question box. I was also wondering in secondary IgA nephropathy, when you have inflammatory bowel disease and you find proteinuria above 0.5, would you actually need kidney biopsy to decide on what to do?
Well, that's just opinion based. There really isn't enough evidence. I would say yes, just because in the realm of what can happen when you have an autoimmune condition, we know that there can be other autoimmune conditions as well. So, you know, it's true that there's a well-known connection between IBD and IgAN, but I wouldn't be completely confident that there's not something else, an underlying different vasculitis. We know that IBD can also be present with membranous nephropathy. It's true that you wouldn't expect hematuria and membranous, but at the end of the day, I think that the benefit of being certain of your diagnosis would, unless there are, you know, other conditions such as severe hypertension or low platelets, you know, something that makes the biopsy, or a single isolated kidney. Unless there are conditions that are sort of very particular, I would recommend performing the biopsy. I also feel, as I sort of tried to hint at the end of my discussion of the guidelines, that the biopsy is also very important to guide the management. So irrespective of yes or no IgAN, I think it also gives you a very much clearer picture of how you need to treat that patient moving forward.
Oh, I have.
But this is just my opinion.
As I mentioned in the beginning, your opinion helps a lot already. I have another question from Carmine Pecoraro. Great talk, Marina. Congratulations. For relapse, urine proteinuria 2 grams per day after 1 year after POTS protocol and RAS blockade, which kind of management would you suggest? That's a complicated one.
Yeah, that's a complicated one. I would probably want to, you know, take into consideration how much of those 2 grams of proteinuria are chronic damage, and so how much of those 2 grams of proteinuria are active inflammatory, to understand. But probably if a full POTS protocol has already been gone through, which is quite a lot of glucocorticoids, I would consider a second-line immunosuppressant, and probably the evidence is not very high quality for any of those. But at this moment, a calcineurin inhibitor would probably be my first chance. But I would also very much strongly hope that in the coming months, we will have clinical trials that we can enroll these patients in.
All right, thank you. And once the POTS protocol has been mentioned, is there like a favorite protocol for you when it comes to oral steroids?
So even there, the evidence is quite scanty. So in the guideline, we gave indications for a sort of common sense approach to both IV and oral glucocorticoids. And so for oral glucocorticoids, we gave the indication to give, depending on the sort of size of the child, 1 to 2 milligrams per kilogram daily for 4 weeks, and then a taper to bring it down on alternate days, you know, between 3 to 6 months to a very low amount of glucocorticoids, and then try to eliminate it completely within 12 months maximum. But, you know, there's really no evidence to guide this, so it's very difficult to know. It really depends on the degree of proteinuria, the degree of inflammation, and we just don't have trials to guide us for the doses of glucocorticoids in this condition, unfortunately.
Okay. Oh, hold on. There's another question. Great presentation. Just relating this to our family experience of IgA nephropathy diagnosis, as with question mark until finally a genetic test age 15 revealed a de novo Alport constant streptococcus infection also, oh, sorry, I have to read that, contributed to proteinuria. Is there any recommendation for genetic testing at a younger age, considering 20% of Alport cases are de novo and IgA treatments may not be compatible with Alport?
Yeah, so that was one of the things that I felt we really tried to move forward in our guideline, and to really give it a lot of relevance in the differential diagnosis, because this is an important story to relay. It's important to remind people of how often IgA nephropathy is diagnosed in patients who then turn out to have de novo Alport syndrome. And so I would say that, you know, if there's a de novo and the patient doesn't have any systemic symptoms, which actively need to be looked for, so you have to look for sensory neural deafness and for ocular abnormalities. But if you don't find any of this, the kidney biopsy will give you the answer, because it will not be compatible with IgAN. And if you're not convinced, you really have to think more carefully, look at those basement membranes, and if you have even a slight doubt, sometimes the IgA immunofluorescence can actually be like slightly positive, but it's really not as convincing as you would expect. In every case in which you're a little bit on the fence and not sure, it's probably best to perform the genetic testing and get that out of the way, because it is very important to differentiate these two cases. Unfortunately, you know, de novo cases are less frequent than family cases, but it can happen. So it is something, I think, in which there's a big margin of improvement by the pediatric nephrology community of being more aware of this possibility of this differential diagnosis and of the fact of missing it. And there are publications where, you know, substantial numbers of children went around with a label of IgAN for years, having been biopsied, and then were subsequently discovered to have Alport syndrome. So we do need to be cognizant of this and good at recognizing Alport syndrome, and it's not always easy.
There's an addition to what you just said, Heidi Sely mentioned that it's important to know that a lot of young X-linked females will not have hearing loss.
Absolutely, you're right. Thank you for mentioning that, Jens.
And there's Thomas Henne with a question who asks, do you have experience with or discuss the role of old school oral budesonide, usually used for Crohn's disease in children, to avoid steroid side effects?
So I think by old school budesonide, he means the targeted release budesonide that you use for example, IBD, I would imagine. So it's not Nefecon, but it's the other forms of targeted release budesonide that are used for gastrointestinal conditions. If I understood that correctly, yes, we do have experience with that. And we actually published in pediatric nephrology a child in our division that we treated, the first one that we treated with this form of targeted release budesonide, because we were unable to obtain Nefecon. And the patient did beautifully, and subsequently we have used in some patients targeted release budesonide instead of oral glucocorticoids to minimize systemic side effects. It is a little bit more expensive, but it's not prohibited, and it can be a good idea. All of the glucocorticoids, including budesonide, have the same problem, that you tend to have the relatively high chance of a relapse or of a rebound once these treatments are discontinued. But it definitely can help to get you out of the woods if you have a patient that's difficult to manage.
Very interesting point there as well. Thank you very much. And now that we're approaching 5 o'clock and I have no further question in the question box, and I know that you had a very, very busy day and probably still have, I'd like to thank you very much, Marina, that you found the time for us and to give us a fantastic presentation on this very complex issue. And I'd like to thank you all for your questions and for listening and following this presentation. And I think I finish by wishing you all a fantastic Christmas holiday and hope to see you back at the beginning of the year. Thank you very much.
Thank you.
Thank you very much.
Bye.
Bye.
Bye-bye.
Bye, thanks.